Good evening, ladies and gentlemen. I am an intensive care medicine specialist. I work here in Dublin in Beaumont Hospital. Our team looks after the sickest patients in the hospital in the intensive care unit. By far the most common condition we see is sepsis. For every 10 patients we look after with sepsis, 4 will die. This staggering mortality from sepsis has only changed slightly over the last number of decades. In fact, we've had no new therapies for sepsis since the discovery of penicillin in 1928. For those fortunate enough to survive sepsis, there are important life-changing sequelae. Survivors report a dramatically reduced quality of life with physical and psychological effects such as weakness, muscle pain and fatigue, reduced ability to concentrate, reduced cognitive function, insomnia, nightmares, panic attacks and depression. And while the mortality for sepsis has reduced over the last number of decades, the incidence, the number of patients that we see year on year is increasing. In our hospital, Beaumont Hospital, and in hospitals like it all over the country, in our emergency departments, in our operating theatres, in our intensive care units, we see more than 14,000 patients with sepsis every year. And in hospitals like our own all over the world, 1/2 of the patients who die with sepsis. So with an increasing incidence, with an aging population, with the problem of antimicrobial resistance, we'll continue to see more and more of these patients in the years to come. So what is sepsis? Louis Pasteur discovered that it was bacteria that leads to infection. But not every infection leads to sepsis. And even when we eradicate infection, even when we eradicate bacteria with antibiotics, that doesn't guarantee a recovery. Sepsis is an abnormal inflammatory response to bacteria. When bacteria gain access to the bloodstream, white blood cells react. They release damaging chemicals that try to control the infection. But this white blood cell response, it can become a runaway train of damaging inflammation that can lead to septic shock, organ failure, and death. And of course, it's not just white blood cells. The lining of blood vessels, that's affected as well. When bacteria binds to blood vessels and when activated white blood cells attack the lining of blood vessels called the endothelium, they begin to leak. Blood clots form in blood vessels throughout the body. So this combination of blood clots and leaking blood vessels leads to a reduction in blood pressure, a reduction in blood supply and oxygen supply to tissues, to organ failure, and sometimes to death. So leaking blood vessels and blood clots forming in blood vessels throughout the body and damaging inflammation, that leads to the clinical picture that we see. So we try to support the circulation with large volumes of fluid and with continuous infusions of medication to try to keep the blood pressure up. Leaking blood vessels in the lungs, that leads to the accumulation of fluid in normally air-filled sacs, inadequate breathing, and ultimately to the need for mechanical ventilation. Through similar mechanisms, the kidneys often fail and patients often require dialysis. That damaging inflammation can affect the gut, it can affect the liver, it can even affect the brain. Patients often require blood transfusions or transfusions of coagulation factors or platelets. So sepsis begins with bacteria entering from the lungs or from the gut or from the urinary tract, or even from an abrasion or a break of the skin. And that bacteria leads to activation of immunity, leads to blood clotting, abnormalities, leads to leaking blood vessels, which can result in organ dysfunction. But it's not the bacteria per se, but it's the host response. It's the body's response to bacteria that leads to organ dysfunction and to death. So I mentioned that we've had no new therapies for sepsis since the discovery of penicillin. That's not through want of trying. I mentioned that inflammation is a factor. It certainly is. In the early stages of sepsis, we see significant elevations in inflammatory factors. But we've discovered that while this is going on, and later on in sepsis, there's exhaustion of the inflammatory response. In fact, white blood cells are not able to respond to infection. They become exhausted, they become unable to deal with secondary infections. So patients who die in our intensive care units often die later from superinfection and from an inability to fight infection. I mentioned that there's an increase in clotting and there's a leakiness in our blood vessels, and that leads to a reduction in blood pressure, and that this leads to organ dysfunction. Again, that's not the only factor. Even when adequate oxygen is delivered to tissues, in sepsis, cells are not able to use oxygen properly, so-called mitochondrial dysfunction, and that contributes to organ failure. So as I said, sepsis pathophysiology, what happens when sepsis occurs, is very complex. So what can we do for patients with sepsis? What do we do in the intensive care unit to try to treat this life-threatening condition? Antibiotics. Early, appropriate antibiotics remains the cornerstone of treatment. The right dose, given as early as possible, can reduce the organ dysfunction that we get in sepsis. So antibiotics and controlling the source and knowing the source of infection remains the cornerstone of therapy. After that, supporting the circulation with large volume fluids and with what we term vasopressor medication that will support the blood pressure and try and support the flow of blood and oxygen to organs to try to prevent organ injury. The other things that we do for sepsis, like gently ventilating the lungs, like trying to maintain the function of the gut by nasogastric feeding, by trying to limit the amount of sedation that we give to patients. These don't treat the sepsis per se, but they prevent other complications from developing. So what do we have coming down the line? What do we have in the pipeline to try to prevent infection from becoming organ injury and death in sepsis? So the first thing to talk about is diagnostics. Currently, when we suspect a patient has sepsis and infection, we take blood cultures. We give antibiotics. The antibiotics we give are the best guess antibiotics because we don't know what particular bacteria, and we won't know for at least 24 hours. With new molecular diagnostics, we could potentially know this much earlier. molecular diagnostic like polymerase chain reaction, like microarrays, which can detect bacteria in blood very early, within an hour. If we can make these therapies, make these diagnostics more accurate, we could potentially diagnose patients much quicker and give them appropriate antibiotics. Our colleagues in Dublin City University are trying to address this with a device that they've developed called Septic. What it does is it takes blood, puts it through a really tiny column of fluid, and with the use of electricity is able to detect whether or not there is bacteria present. So at the moment we're helping in Beaumont Hospital to validate this device, and we're hopeful that it could be used as a point of care device, that is a device that we'd use beside the bed to indicate the presence of bacteria or not. All across the world, we're trying to find a marker for sepsis, a blood marker that we term a biomarker. If we could find some marker in blood that would tell us this patient has sepsis, or this patient has sepsis and has responded well to the antibiotics, it would be really very useful. If we were able to find a marker that told us about the different stage of sepsis, because again, not every patient is the same, and not every patient is in the same stage of sepsis. I mentioned at the very beginning that inflammation at the start can be rampant. Then later on, inflammation becomes exhausted. So if we were able to develop a biomarker that was able to tell us about the particular stage of sepsis, we might be able to develop a drug to target that stage of sepsis. And with computers and with something we call systems biology, we can use data from genetics, from epigenetics, from all the protein molecules that are secreted by white blood cells to try to develop a biomarker. Again, if we are looking to develop therapies for sepsis, we have to understand that not every patient with sepsis is the same. And even the same patient with sepsis at an early stage will be different to what they're like at a later stage. So early on, patients die because of this hyperinflammatory response, because of this out of control white blood cell response. Later on, they die because their immune system is exhausted. If we're going to develop drugs, we need to develop drugs to target the particular stage of sepsis. So I'm going to talk briefly about some of the medications that have shown great promise in early stage clinical trials. So GMCSF is a drug that is most commonly used in the chemotherapy world to try to stimulate white blood cells when patients have had chemotherapy and those white blood cells have been knocked out. GMCSF has shown a lot of promise in early clinical trials when it's been used in patients whose immune systems are depleted. So a large French study due to finish this year will test GMCSF in 488 patients with sepsis. And the hope is that it will show an improvement in both their immune system and their mortality. Similarly, interferon gamma, which is a drug that has been used successfully in other immune conditions like multiple sclerosis, has shown promise again in terms of stimulating the immune system in patients whose immune system is exhausted. I mentioned clotting. Clotting is a big element of sepsis, widespread clotting. And this widespread clotting contributes to organ failure because it stops blood and oxygen from getting to tissues. if we could interfere with the formation of clots, we could perhaps reduce the burden of organ dysfunction and organ failure in sepsis. So a drug called thrombomodulin has actually been licensed for use in Japan just last year. Here in Europe, we're waiting for stronger evidence. So currently another both European and North American clinical trial in 800 patients with sepsis is due to be finished this year. Hydrocortisone is a drug, a steroid drug, that we've used in sepsis for many years, with a lot of debate in the medical fraternity about whether it's useful or not. Just recently, in fact, just this week, a trial has been published in the New England Journal of Medicine, which is a big medical journal, one of the most important medical journals, that has shown hydrocortisone has some benefit for patients with sepsis, but it's not a very big benefit. It doesn't save lives. It gets patients out of the ICU quicker. It gets them out of the hospital quicker. But unfortunately, there wasn't a mortality benefit. Other things that we're doing. We're using cooling. We're using blood purification methods. So extracorporeal treatment. So taking patients with sepsis and filtering their blood, putting it through a filter to try to remove the substances that we think are driving the organ failure, driving the inflammation. And that's been tried for a very long time without much benefit. But the good news is that the technology is getting better, and the people who are experts in blood purification feel that new devices might provide some benefit. So a study has just finished called Euphrates and will be published this year, and we hope that that'll show some benefit. Getting rid of bacteria in the gut in general in patients in the ICU is called selective decontamination, and that has shown a lot of promise. Again, another big study that will be published in 2019 will give us definitive data on that. I want to talk briefly about a drug that has been developed here by Professor Kerrigan's group. And I suppose what's interesting about this drug is it's been developed from the ground up. What Professor Kerrigan's group has shown is that when bacteria get access to the bloodstream, it binds to the lining of blood vessels. It sticks to those linings. And it hides out there, and it can hide out from antibiotics. So Steve and his group have developed a drug that actually interferes with that binding, stops bacteria from binding to blood vessels. The results that he's shown up to now are really very promising, and there's lots of advantages to a drug like this. It acts early in the infection process. It's not an antibiotic, so we all know that there are problems with antibiotics and antibiotic resistance. It seems to work on every type of bacteria, and it seems to be very safe. So there are early stage studies going on here in RCSI of this drug, and we hope that we'll be able to take it forward and bring it to patients with sepsis. I'm going to talk briefly about my own work. I'm interested in stimulating the immune system. So I talked about the runaway train, the out of control inflammation. Well, one thing does work very well in sepsis. That's our white blood cells. They can identify bacteria, like this macrophage here, white blood cell. It identifies bacteria, it chases those bacteria, and it can eat them. And it can kill the bacteria inside the cell without causing much inflammation. So if we could stimulate the immune system to do more of this, we might make an impact on sepsis. So we've identified stem cells, adult stem cells that are present in bone marrow that can enhance the process of eating bugs and killing bugs inside white blood cells. So what we'd like to do is to treat patients with sepsis with these stem cells. And we're accumulating the evidence in order to get approval to do this. We think it's a very promising therapy. So in summary, I'm a critical care physician. I work in the ICU and I see patients dying with sepsis every day. We've made some progress. We've made progress in terms of identifying patients as soon as possible, in terms of treatment protocols that mean that our patients are getting the best treatment, the right treatment, as soon as possible. But we still have work to do. And the work we have to do is to improve awareness, not just among medical personnel, which we're getting better at, but also among the public. Because if we improve awareness among the public, patients will come earlier. Patients will have sepsis on their minds when they're presenting with sepsis-like illnesses. And with this work and with the ongoing work that we have in terms of new drugs, we can hopefully make this situation change and have no more deaths from sepsis. Thank you very much for listening.